Hello, and thank you for joining the POCUS Certification Academy for today's POCUS Bites webinar. My name is Tori, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for any comments you have throughout the webinar. Today's topic is appendicitis in pediatric population, and our speaker is Falguni Patel. Falguni is not able to be with us today due to work demands. However, she will address questions that you submit through the Q&A box and will send answers back to you in an email within about a week. Falguni Patel has been an advanced pediatric sonographer at Lurie Children's Hospital in Chicago for over 20 years. She earned her associate's degree in diagnostic medical sonography from Triton College in River Grove, Illinois, and earned her Bachelor of Science degree in medical sonography at the Oregon Institute of Technology. She is credentialed by the American Registry of Diagnostic Medical Sonography in abdomen, OBGYN, neurosonology, pediatric, vascular technology, and musculoskeletal specialties. She volunteers and presents for various professional organizations within sonography, such as the Society of Pediatric Radiology, the American Registry for Diagnostic Medical Sonography, and the Society of Diagnostic Medical Sonography. She currently serves as the chair of pediatric sonography specialty at RDMS and recently presented at our POCUS World Conference and helped raise awareness of ultrasound globally. Please welcome our speaker today, Falguni Patel.
Hello everyone, my name is Falguni Patel and I am an advanced pediatric sonographer at Lurie Children's Hospital of Chicago. And today I will be presenting on role of ultrasound in diagnosis acute appendicitis in pediatric population, one of the most challenging exams to perform and learn to scan when you're new in the pediatric field. So let's get started. All right, so the learning objectives would be to describe the anatomy of the appendix, indication of an acute appendicitis. We'll go over some sonographic findings of the acute appendicitis, secondary sign of an acute appendicitis, scanning protocol of normal and abnormal appendix, and then finally we'll review some interesting cases. So appendicitis is actually one of the most common abdominal emergency. The lifetime risk of developing appendicitis is approximately 7% and usually requires surgical treatment. Acute appendicitis may occur at any age, but although rare in the extreme of the age. So that's why ultrasound is considered the most appropriate initial imaging modality when it comes to the pediatric population. And just to give you a little explanation of the anatomic location of the appendix, as you can see, this is the cecum, and then the appendix comes off of the cecum where there's a blind end, and then the tip is at the bottom. So this is where the appendix is located, most of the time in the right lower quadrant. So this is what just a typical appearance of a normal appendix would look like compared to the inflamed, which is an abnormal appendix. A normal appendix is nice and thin, and it gets really challenging to find normal appendix on the ultrasound, but it gets easier as appendix gets inflamed. And here is a beautiful analogy of showing you what a normal appendix looks like. It's basically a thin appearance of a rope, and then as obstruction starts, the fluid starts building up and it gets distended, and then finally their wall gets distended due to the ischemic necrosis, and then it ruptures at the end. So this is a beautiful demonstration of going from a normal appendix to the ruptured appendix. Now there are various stages of appendicitis as well, but the most common causes of appendicitis is an obstruction of the appendix due to either fecalith, appendicolith, or lymphoid hyperplasia. And as you see in these images, when there is an obstruction that happens, these kids start feeling the abdominal pain. And as the obstruction progresses, then it becomes dilation, distension, and then finally the perforation. But the cause is due to some type of obstruction, which sometimes we see it on the ultrasound and other times we don't. There are some importance and limitations. So in order to rule out the importance of the ultrasound, it's the best choice of modality compared to the other modalities because it has zero radiation, it's quick, more efficient, easy access compared to CT or MR. But then there also comes with limitations. It's totally an operator dependent study. Patient factors such as bowel gas and obesities can also be the limitations. Now, there are indications to keep in mind when you're looking or scanning for appendicitis, such as right lower quadrant pain, high fever, nausea and vomiting, bear down episodes, and of course, elevated WBC. There's a tenderness in the right lower quadrant at McBurney's point, and that area perhaps is the most useful clinical findings. So, as a sonographer, when you start scanning the patient, always keep an eye on how actually the patient is feeling while you're scanning, because that is very important to know the clinical findings as you're looking for an appendix. Also, differential diagnosis and complications is important to remember. Now, you go in to scan an appendicitis, and next thing you can find either intussusception or microdiverticulum, testicular torsion, kidney stones, vital bowel obstruction. All right, so let's talk about the sonographic appearance of layers of normal appendix. Now, the normal appendix can be very challenging to find on the ultrasound, but if you happen to see one, it involves different layers. So the most inner layer is the mucosa, the second layer is the submucosa, the third layer is the muscularis purpurea, and the outer layer is the serosa. On transverse images, we see mucosa, submucosa, and muscularis purpurea in a very detailed orientation. But the appendix is made up of 4 layers. The classic sonographic appearance of a normal appendix would be that it usually measures less than 6 millimeters in diameter, not inflamed, and easily compressible. So here's a beautiful demonstration of showing you what a normal appendix on ultrasound can look like. It's very, very challenging to find a normal appendix because it really mimics a loop of bowel. But some things, important tip to remember is when you're scanning for appendix, you can always follow through the cecum, and then the tip is very helpful landmark to assure that that is an appendix, because any other loop of bowel will not have a tip, whereas the appendix will have a blind end and a tip. So that's something to keep in mind. And then also the dual image helps with the compression. If the appendix is not inflamed and it's negative, your compression view, it's going to compress easily. And then the diameter is usually going to be less than 6 millimeters. And just from the experience of being a pediatric sonographer, I have also noticed when there is a negative appendix present that bowel loops in that right lower quadrants are very normal looking, and there's going to be a lot of peristalsis happening. So that's something to also look for, which is one of the secondary signs that we will talk about in a few slides over. But that's important sign to see, pay attention, what is the surrounding bowel doing in that right lower quadrant area. Here is another beautiful demonstration of showing you a normal appendix. Most of the time you'll see it above the iliac vessels. And then here is just giving you an indication of showing you where the cecum is in relationship to the appendix. And then here is the tip. And here are some more examples sharing you what a normal appendix can look like on an ultrasound. Like I said, it's a very thin layer of appendix. Sometimes, it's challenging because it's not inflamed, but once you get really good at it, it gets easier for you to identify on the ultrasound. I highly recommend to look for a normal appendix because that totally saves patients from an additional imaging. So it's important to document normal appendix if you happen to find it. And if not, then they can always order an MRI, but by finding a normal appendix, you can definitely save patient from an additional expensive exam. But here is a beautiful demonstration of a younger patient, and as you can see, a normal appendix is nice and small, but you can see the tip is separated from the rest of the loop of bowel. So that's for sure is an appendix. All right, there are a couple techniques to also look for, and I said earlier to follow through the cecum, and then here's the tip. That is your indicator that that is an appendix for sure. And then the compression technique is also very useful. A normal appendix will be easily compressible, whereas a positive appendix will not be able to compress. But it's always important to document compression views with and without compression. Okay, so let's go over the sonographic appearance of the appendix. Now, the appendix can appear as in a simple form, complicated form, mass-looking appearance, or finally the abscess. So when you visualize the appendix, as you can see, the top image is normal as we can appreciate different layers of this appendix. And the bottom appendix is completely abnormal. It has a lot of appendiceal, periappendiceal fat. It's inflamed. You can see it's filled with debris and fluid, and of course there is an appendicolith present. So this appendix can become into abnormal appendix as a matter of time, but you can appreciate normal versus abnormal in this slide. So what is the criteria for appendicitis? So remember, criteria is the transverse measurement of greater than 6 millimeters. So AP measurement is more crucial and compared to the length of the appendix, because it can be long and tortuous and you probably not be able to get the entire appendix. That's why the transverse measurement is more accurate. It's non-compressible. The aspirity of appendix is also very important to document. Appendicolith may or may not be present. And then, of course, perforation, abscess, periappendiceal fat infiltration, periappendiceal fluid, adjacent bowel loops are not peristalsing around the appendix if it's present. And then, of course, patient tenderness is also something to keep in mind. I've also learned throughout my career that there's a thing called tip appendicitis, where overall the appendix will look very normal, but it's the tip that is dilated, and that can be also very painful for these patients. So when you are looking for an appendix, I would recommend you to evaluate in its entirety and find the widest portion before you start making a measurement. So once you find the widest portion, that's where I would recommend you to do a dual image with and without compression, and then also make a measurement, an AP measurement, to make sure that that appendix is not inflamed. So that tip appendicitis is also important to document. Okay, so probe selection, most of our images we use linear probes, but it also depends on the body habits of the patient. Well, especially when it comes down to the pediatric population, we rarely use the curve, but there are times where we have used curved in our practice, but mostly we go with the linear as it's a higher frequency transducer and it can give you a better resolution. All right, so clinical presentation. Now, appendix can have various positions. So if you're new in the field or you're learning through how to scan appendix, just remember that appendix can lay in various stage and phases in the body. And if you can look at this beautiful demonstration, different location of the appendix. If you draw an imaginary line on the anterior part, it can be posterior, pre-ileal, and pelvic. And then posteriorly, it can be retrocecal and subcecal. So that's why when you have this impression that you're looking for appendix only in the right lower quadrant, a lot of times you're going to miss it because of various position in the appendix. And that's why we have a very strict protocol that we follow when we're scanning appendix, because it can be anywhere. But just something to keep in mind with the clinical presentation, it has shown that the retrocecal appendix can present with back pain or flank pain. Pelvic appendix can present with suprapubic pain, and then long appendix can present as a right upper quadrant or left lower quadrant pain. So just keep in mind to cover this entire abdomen area to look for appendix. I've also noticed that there are few cases with the appendix in the left lower quadrant because patient had situs inversus. So don't, try not to ignore the left lower quadrant. Also make sure you document that as well, showing that there's no appendix present in that area. There are a couple of techniques that I recommend you to use in your workflow if you're struggling to see that right lower quadrant. One is the posterior compression technique, which is the addition of the posterior manual compression to the graded compression, and it can help to identify the appendix more clearly. And this technique has it's very easy, but it definitely works on a patient. So try using that. And then the second is the positional scanning, where it's a posterior lateral approach, and pelvis, in addition to the right lower quadrant, may also be useful. And just like, changing the position can get rid of the gas, and it can help you visualize that appendix better if it's present. And then this is one of my favorite slide, because it really gives you the impression of not only go in to look for appendix, but also pay detailed attention to the secondary sign. One of the most important sign is free fluid. Now, everybody can have a little bit of free fluid, which is physiologic, but if you happen to start seeing a significant amount of free fluid, that is your biggest indicator that there might be something going on in that belly as the child is symptomatic. Secondary thing to look for is also your lymph nodes, where they can have several lymphadenitis. And then, of course, a periappendiceal fat. That is your most important clinical sign, sonographic sign to look for. And then, if you happen to find an appendix, of course, measure it, to see how big it is. And then the dual image with compression is also very useful to rule out appendicitis. Now, either you're going to see the appendix or you're not going to see the appendix. So if you happen to see the appendix, then keep in mind that visualization of the appendix with loss of the echogenic submucosal layer, large amount of periappendiceal fat will be present, and the presence of an intraluminal appendicolith may or may not be present. Now, if you happen to not see the appendix, but instead if you happen to see an abscess that appears as an hypoechoic or complex mass with internal echoes, then that appendix might have ruptured. That's why keeping those secondary signs in mind when you're scanning is very, very important, because you're not only looking for the appendix, but you're also looking for the ruptured appendix at the same time. So there are a couple treatment plans. If you happen to find an appendix on a patient, then they are going to get a procedure called laparoscopy appendectomy, where they go in and simply take the appendix out. Now, if you happen to find an appendix that is ruptured or in the process of rupturing while you're scanning, which I have seen several of them, then that patient will get admitted and will start an IV antibiotic treatment for a week. So time plays a crucial role when it comes down to appendicitis. The sooner we get the patient, sooner we provide our services, then it gets, the treatment plan gets made for them, and hopefully they don't have to go through the treatment after the rupture happens, because that is very painful and a longer process for a child to be going through that. That's why I always recommend, if you have an ED patient for an appendicitis, please put a stat order on that. All right, so a couple challenges that we deal with, of course, is the bowel gas, and sometimes it's just nothing. You can try every possible way, but you just cannot get rid of that gas, and you're not able to evaluate that area in the right lower quadrant. Just be honest about it to your radiologist, and then, of course, they can always recommend MRI or CT as a second modality for that patient. Now, there was a recent research article that was performed by Fabbit and Arman, and they basically said that a positive ultrasound results with ultrasound performed by a qualified provider is diagnostic. So that's why that operator skills as sonographers have to be confident in order to be doing and performing this test for appendicitis. In 92% of their cases, they use ultrasound as their first line of imaging modality. So that tells you how much, the ED depend on the ultrasound modality when it comes down to rule out appendicitis in the pediatric population. So with that said, I'm going to go over some interesting cases for the acute appendicitis. So I have few cases piled up that's going to show you what a normal appendix looks like, and then few to show you what a positive appendix will look like. So here is my first case. We had a 9-year-old girl presented to the ER with a history of abdominal pain. Our first images that we like to capture is start with the bladder. So not only we are focusing on the bladder, but we are actually looking for any type of free fluid, in any other findings, such as ovarian pathology. When it comes down to a female patient, we automatically change the order to a pelvic complete with Doppler. If the patient is older than 5 years of age, most of the time ED is pretty good about ordering the dual orders on these patients to rule out appendicitis and ovarian torsion. But if not, then we always question the ER if they would like pelvis or not. So here's a beautiful demonstration of showing you um, normal appendix with it's long and thin, so there's it and tortuous, so we are seeing these transverse loops in several areas here, but that is a normal appendix. And with compression, you can see this is an appendix, and here with compression it's out of the view, so it's easily compressible, it's not as hyperemic. It's always good to prove the flow also of the appendix. And then it only measures 0.6, so this is a borderline appendix just because it was a little bit over the 6, but again asymptomatic. Another patient presented to the ER with abdominal pain and 4 to 5 episodes of emesis. So we started with the bladder. We are not seeing much in the bladder. And then, of course, both the iliac fossa showing you right lower quadrant, left lower quadrant. And here is the beautiful demonstration of the appendix. And there is an appendicolith present in this appendix there. It's fluid fill also, but you can see a beautiful layer of the I'm so sorry. Please pardon me with the background noise. There's a beautiful layer of the periappendiceal fat in this appendix, and then there is a nice, beautiful appendicolith giving you a nice posterior shadow. And so this was read as an acute appendicitis with appendicolith without evidence of perforation. Couple images that we also include in this protocol is to look for right kidney and the left kidney, and sometimes just to look for just as simple as any kidney pathology, because that can also cause an abdominal pain, such as hydronephrosis or sometimes kidney stones. So it's always good to throw a couple pictures of the kidneys to make sure that you're ruling out kidney pathology if there is anything present. And here we're just kind of showing you that with compression, this appendix is not compressible. And then here, beautiful demonstration of the appendicolith. Okay, another case to show you, 15-year-old presents with 10 days of right lower quadrant pain and fever for 4 days and vomiting. So here you're shown, basically you can't really tell what exactly this area is, but it's actually the ruptured appendix with a little bit of loops of appendix right here, where we are seeing all the abscess collection in that right lower quadrant. And this is what a typical ruptured appendix will look like. Again, you're not going to be able to catch it right away in the beginning of your profession, but as you get more skilled, and you just know that you're not seeing the normal loop of Bowes peristalsing around it, and this more likely is the rupture. All right, here is another patient. It presented to the ER with the right lower quadrant pain, 2 days for 2 days and abnormal labs. Beautiful demonstration again of the right lower quadrant. I always also suggest to use the body marker so the radiologist knows exactly where you're scanning, because once in a while this appendix can also be on the left lower quadrant. So that's why that body marker is very useful and can be used as a reference for the radiologist to see where exactly the appendix is located. And it's also very helpful for the surgeons to know that if they need to remove it. Here's a beautiful demonstration of couple appendicoliths. So when there's an appendicolith present, it makes it easier to see it on the ultrasound. And then once it's there, you just, kind of show it, measure it, and then here is another beautiful demonstration in transverse, but pay attention to the periappendiceal fat. And like we said, there's not a normal loop of bowel that is peristalsing around it. So that's something to also look for. The area looks very, very hyperechoic, and there's not a whole lot of activity that's happening. But this was read as an acute appendicitis with 2 appendicolith. All right, this is another patient that presented to the ER with severe right lower quadrant pain. And this is the classic appendicitis. You put the probe in the right lower quadrant, and right there you have it. Beautiful demonstration again of the transverse appendix, long appendix. And you can see this is filled with debris and pus and all this periappendiceal fat right around it. This patient was in excruciating pain. And again, the measurement was way over 6 millimeters. This is measured in centimeters, so it's 1.7. And beautiful demonstration again of the periappendiceal fat that is just surrounding the appendix. Not a single loop of bowel that is peristalsing in that right lower quadrant. And here is just a longitudinal view of the appendix showing you it's not as hyperemic though. Now I've seen a lot of appendix when they're inflamed, they can be hyperemic. That's why the color flow is very important to document, and this was read as an acute appendicitis. Here we have another case, and this case reminds you and shows you how important our role is as a sonographer to scan and see what we're supposed to see, and then how much the time plays an important factor when it comes to the treatment plan for the patient. So we had an 11-year-old male patient presented with a severe abdominal pain, mild fever, constipation for 4 days, inability to tolerate food intakes, and non-bloody stool. So as you can see, excruciating pain. I started scanning in the right lower quadrant, and there is the appendix. And again, look at all the collection of the periappendiceal fat around it. There's a huge appendicolate present with a beautiful shadowing in the background. And then more demonstration for you. Here's a beautiful shot of showing you in transverse, and the AP diameter was 2.5 centimeters. This patient was so much in pain, and I was trying to rush and get the images as soon as I can, just because I had a feeling it was going to rupture. And as I'm further scanning, again, I saw this huge appendicolate, and then document, with measurement. Compression, in a case like this, you can rarely compress, otherwise you will end up rupturing it. So just be mindful of when to compress and when not to compress. When you actually see this big of an appendix, there's no need to do that compression view. But also I noticed this bright aquagenic area that happens to be the actual tear in the appendix that was happening in the moment of rupturing. And so there's no flow with the color image. And here is a beautiful demonstration of the periappendiceal fat. And as you can see, changing the probe sometimes helps, but also I got this series of images. I took the sector, the cross beam off, and it really enhanced the image really nicely. And then there was also a lot of free fluid present in that same area. So this was read, and again, here is that bright aquagenic area, that rupture site in the wall of the appendix that I mentioned earlier about. And so I saw it very clearly on these images. And so this was read as a markedly dilated appendix with AP diameter of 2.5 centimeters with a large shadowing appendicolate, small aquagenic focus near the wall of the appendix, and periappendiceal fat with free fluid. This was an acute appendicitis with markedly dilated appendix and appendicolate. So as soon as the ultrasound was performed, the patient was rushed to the OR, and pre-op diagnosis was made. It was an acute appendicitis. Post-op diagnosis was made where the acute appendicitis had perforated, and the procedure that they performed was a laparoscopy, appendectomy. Well, after the whole thing this patient goes through, 1 week later, post-surgery, patient was still complaining of abdominal pain. So the CT was ordered for further evaluation. And on CT, they demonstrated 2 dominant fluid collection with right upper quadrant and right lower quadrant suggestive of abscess. So after the patient gets CT, then the patient gets transferred to IR for abscess drainage percutaneous was performed next day. And here is what that fluid abscess pockets that they were talking about in the right upper quadrant and right lower quadrant. And then a week later, from the drainage placement was placed, patient was released. So this just shows you how crucial it is to bring the patient to the ER. And then when we come in the picture as a sonographer and then how fast we perform our scan, and how fast the OR takes care of the patient. So everything is linked with each other, but I feel like we are the first a group of people that will actually scan this patient. The sooner we do our part, then it gets faster as the case progresses. And so that's why time plays a crucial role when it comes to rule out appendicitis. And it all starts with us. I have a couple examples just to show you ruptured appendix, as it's very hard to see it on the ultrasound. But just from years of experience, I have noticed that when you start looking for an appendix, and again, don't only look for appendix, but look for those secondary signs that I keep reminding you all about. But a lot of times with the ruptured appendix, you're going to see bits and pieces of appendix. You're not going to see that nice long tubular structure that you are used to with. So here's a beautiful demonstration of a floating appendicolith, and then here's a nice collection of abscess. And just, the more you scan, you're seeing not a whole lot of bowel peristalsing, but just fluid collection and these pieces of appendix with a little bit of free fluid as well in the corner here. But that fluid filled bowel is not going to be there. Okay, so here is another case that's showing you ruptured appendix, right lower quadrant. As you can see, you're not going to see again the tubular structure, but you're just seeing bits and pieces of appendix, and then not a whole lot of normal bowel, but the bowel is super echogenic and bright. Here is the abscess collection. And then a free floating appendicolith in that right lower quadrant. At this point, rupture is happened and a patient seems very lethargic, but this is also a very important finding, so that the treatment plan can be made based on what we see on the ultrasound. The one thing to keep in mind is when you have a free appendicolith, no matter if you go longitudinal or transverse, it's going to really not change the shape as much. So that's how you can differentiate an appendicolith free floating versus just the consistency in the bowel, because a lot of times peristalsing of bowel can also have material that mimics the appendicolith. So that's how you can differentiate it. So key points to remember: transverse AP measurements of greater or equal to 6 millimeters should be non-compressible. Vascularity may or may not be present. Appendicolith may or may not be present. Perforation, abscess, periappendiceal flat. In fact, periappendiceal fluid is very helpful to find appendix on the ultrasound for us. And then remember, absent of adjacent loop of bowel peristalsing. And then patient tenderness is also super important for us to keep in mind when we're scanning this patient. So here is the scanning protocol that I recommend you to see if that will help you with your workflow. Everybody does a little bit different scanning, but if you follow this protocol strictly, in my experience, you will never miss another appendix, because we really cover it thoroughly. And at Lurie Children's, we are pretty good about evaluating appendicitis. In fact, our ED highly depends on the ultrasound, and we rarely order MRI. And there's a couple factors to it. The machines are getting so much better. The resolution is improving significantly. So we are seeing not only abnormal appendix as much, but also normal appendix quite a bit. So if you follow this protocol, make sure you start with document bladder and trans and long. Now this protocol is for the looking for an appendix. So this is just starting from scratch. We're going to document right and left iliacs in transverse and longitudinal. Document right lower quadrant in trans and long, and take cine clips of the right lower quadrant in longitudinal and transverse, and then cine clips with compression from right upper quadrant all the way down to right lower quadrant. And that's important to show how much loop of bowels are active in that area. And then, of course, document the right kidney that we talked about before, demonstrating the Morison's pouch and the liver, and then also documenting the left kidney and the spleen. So if you see this diagram, we are focusing not only in the right lower quadrant, but starting with the pelvis, and then right upper to right lower, and then left upper to left lower. So this protocol is to look for an appendix. Now, if you happen to find the appendix, then these are the additional images that you're going to add to this previous protocol. You're going to document inflamed appendix in longitudinal and trans. but you're only going to measure it in transverse, the AP measurement. And remember that tip appendicitis in mind that we talked about. So make sure you find the widest portion of the appendix before you actually put your calipers on, because that is very important, especially with the tip appendicitis, because that will definitely change the patient treatment plan if there happens to be a tip appendicitis versus a normal appendix. You're going to document the dual image of appendix in transverse with and without compression. And then you're going to measure the appendicolith in both long and trans. And if multiple appendicoliths are present, highly recommend you to measure as many as you can. And then also document the flow in longitudinal and transverse appendix. Cineclip is also very important, where you're showing the blind end of the appendix and heading down to the cecum, because that's how you're going to differentiate a regular loop of bowel versus appendix. And then, of course, secondary signs such as free fluid, lymph nodes, and periappendiceal fat. And then always remember to check on your patient while you're scanning, and also see how the patient are doing, and communicate, what patient was going through when you were scanning with the radiologist, because that also helps. So in conclusion, ultrasound should be the initial imaging study of choice for pediatric appendicitis because it's rapid, non-invasive, inexpensive, and requires no patient preparation or contrast administration. Ultrasound examination also to rule out appendicitis is totally dependent on the operator skills. And that's why ultrasound plays a major role in diagnosis pediatric acute appendicitis. And always remember, to all my sonographers out there, not only pediatric sonographers, but any sonographers out there, and whoever is learning to scan, especially with POCUS world, be grateful for our talents. Remember, our images makes huge difference in saving our patients' lives. And remember to always go above and beyond for every patient we serve. Don't give up easily. Always use different approaches to scan patient. Thank you very much. Any questions?
Thank you, Falguni. Great presentation.
Thank you.
Thank you. Thank you for being here. So you are here live with us. We can address some of the questions that came in throughout. And I know, audience, that there were a couple that were answered on the fly that she was able to provide written answers to. You can check your Q&A box there for that. But we've got a couple others that came in throughout. So let's just go ahead and take a moment and address those. And while we're addressing those, audience, if you have other questions, please type them in that Q&A box on your screen, and they will get to us, and then we'll address them for the group. So we'll just start at the top. The first one that came in: how common is mucus? I'm not a clinician. I will just put that out there. So I don't know what some of these words are. How common is mucocele of appendix in children? Any specific signs?
It's hard to differentiate those between the appendix, but as long as you find a classic appearance of an appendix, that's all they're looking for. But I will say it's hard to differentiate between the two. Also, when it comes to appendix, you're looking more for the tip of the appendix, because that's for sure is a uniqueness about the appendix versus Meckel's or versus any other bowel issues, especially with neck and things like that. So that's why that diagnosing the tip and the blind end of the appendix is very important.
Okay, great. So our next one is how common, nope, let me see, I missed one. Any role of elastography in detecting an impending rupture of appendix?
That's a great question. We have started elasto in our department, but we are not quite there when it comes to appendix. We have started with liver. But I'm sure I read a few articles that are out there that they're using elasto for that. I'm not exactly sure how accurate it has been. It's still in the research process, but down the road, this is why our field is growing on a daily basis. I'm sure that's happening down the road, but we haven't been using elasto when it comes to appendicitis.
Okay,
thank you.
Great. Yeah, great. Some other people making comments. Awesome presentation. So we're going to get some of those, and yeah, please give kudos where due. Another question: what's the best ultrasound sign to diagnose an omental infarct?
Honestly, we haven't been seeing those a lot. I will say we just started using the neck protocol for scanning that. Again, it comes to limitations with ultrasound for things like that. Sometimes the patient can be very gassy, and not the beautiful scan. So that's where the limitation happens. And they don't really depend on ultrasound for that kind of structures or pathologies.
Okay, great. Another question that came in. Yeah, group, keep them coming. Which ultrasound probe would you start with?
So it all depends on the body habitus of the patient, but I will say we have Logic E9s and E10s, and the two go-to probe I would say would be your linear. But my personal rule of thumb is I use multiple probes. I start my scan with the curve to show the iliacs and the bladder and to look for free fluid. And then I will switch to the 9 linear because it has a better penetration. And that's what helps me to actually find the appendix. And once I find it, now I want to investigate further into what the makeup of the appendix is. So then I will change the probe to the higher frequency, which is 15L. And that is a beautiful probe because it really gives you that detailed resolution of the appendix itself, like rupturing of the wall side or appendicolate, or even if there is any debris present in the appendix. With the resolution we have, it's always nice to use different probes. I feel like each probe has its own uniqueness, and you will always get more information by using different probes. Also depends on the cooperation of the patient. A lot of times they're in a lot of pain and they're not going to let you touch you and whatnot. So when there is an emergency like that, your go-to probe would be the linear probe, whichever higher or lower frequency you have.
Okay,
great question, though.
Yeah. Another one came in. Any better techniques in patients with large body habitus and a lot of gases?
Sure. So we talked about a couple things in my presentation. One was the position change. You can always decube the patient in the right lateral or left lateral decube position to get rid of the gas a little bit. And also that posterior compression technique that I was telling you guys about. That has been very helpful. And a lot of times it's just a simple thing. It's just emptying the bladder. When we walk in the room, that's why I recommend everyone to start with the bladder, because that's your first clue. If the bladder is over distended, take that extra step, have them empty the bladder so it automatically gets better for you to visualize that right lower quadrant area. It's just sometimes that simple limitation of bladder is not letting you see what you need to see. So just keep in mind, hey, the bladder is full. Let's just do a quick post-void, and then we'll start with the detail scan for appendix. But I've tried, using those couple approaches. It has really helped us throughout my experience of working here, that it really helps you visualize the appendix better. And then, of course, changing the probes and going down. Using your knobology is also other thing. Change the protocol, change the settings on the machine. But emptying that bladder is really helpful.
Okay.
Great question.
Yeah. Another one, if appendix was not visualized and secondary features of the appendicitis were visualized, can someone write, quote, appendix not visualized, however, secondary findings are consistent with appendicitis as impression?
In the impression from our radiologist workflow here, if there is a secondary sign present, they will describe that in the report, but that's not really ruling out or appendicitis if it's there or not. But if you see, like I said, ruptured appendix is easier to see with the demonstration of all the secondary signs that we talked about. But if there is a significant amount of free fluid, they will investigate further into it and not release the patient, whether we see the appendix or not. So that's why keeping that secondary sign in your images is also, at least they will, worst case scenario, they will end up ordering an MR on the patient before they release them. So it all depends on what's the severity of the secondary signs you're proving it. So that plays a huge role of just proving that if there is enough significant lymph nodes are present, or if there is enough free fluid in the, and then a patient's symptoms also is a very helpful factor.
Okay. All right. Great.
Great question.
Excuse me. I think that is all the questions that have come in. So, audience, thank you for attending today. And Falguni, thank you for jumping on. I know
Sure.
you're super busy at work right now, but we appreciate you being here to answer some questions and great presentation. Audience, we do have some poll questions. I'm going to go ahead and launch those now. So if you would take a couple of moments and answer a couple of questions for us, that would be fantastic. And I'll leave this open for a little bit, but that does wrap up our webinar session for today. We do record these, and a recording is going to be available on our website in approximately a week. So you can always come back to that and review that if you'd like. But thank you for attending our webinar today. We look forward to seeing you on a future webinar. And Falguni, thanks again. Appreciate you being here.
Thank you, everyone. Thank you for listening. Have a great day.
Thank you.
Bye-bye.
You too. Bye.
Bye-bye.